But good afternoon, everybody. Welcome. I hope everybody's having a really good conference so far. I'm really excited to be here doing these back, seeing people face to face versus, doing all the virtual stuff. I did want to start off just giving a big thank you to our host, all the staff here, all the work that's gone into making this a successful conference. There's a ton of work that goes into it, so just want to recognize that. The sessions, I think, so far have been fantastic. I'll try and not mess up that momentum. But as Mike said, I'm here to talk to you today about data and high-cost claimants. Now, this is a topic I am super passionate about. I think that'll come through the discussion today. I hope to be able to provide you just some unique perspectives or insights for you to take back in your day-to-day responsibilities. We will try and have some fun along the way. In terms of the agenda, just really quickly, I'll provide a quick introduction of myself, just being new to a lot of you. We'll get into some of the current state, talking about facts and figures related to high-cost claimants. Then we'll go into what I consider to be some of the key drivers of what we're seeing. Today, we'll focus around chronic conditions. To make sure it's not all doom and gloom, we will get into some techniques that I think you can use to help manage high claims activity. For that component, we'll actually focus in on data integration and predictive modeling. And then we'll wrap up with a little bit more on gene therapies and build on a lot of that great content that Rob laid out for us earlier. So quickly about me, my name is Wes Smith. I'm really excited to be here. Again, like I said, I live just outside Louisville, Kentucky, which is not far from here. I've been working in consulting and healthcare for about 15 years. That includes time spent at Anthem, time spent at Mercer, and most recently working for a data warehousing and analytics vendor called Certalytics. You will notice these slides are branded with Imsana RX. That is because I actually changed jobs last week. Fortunately, because I am a huge nerd and do basically all of this research independent of my daily job, it had no effect on what I plan to present to you today. But I do apologize for any confusion between the materials and everything, and apologize to Rochelle for throwing that wrench in right at the last minute. So that's the quick explanation. I am an actuary by trade. That just means I spent entirely too much of my adult life studying for standardized exams. But people generally believe anything that I tell them, so that's kind of nice. I have an awesome family at home, a wife of 16 years. I do actually have 5 kids. That includes a set of twins. My twins were born March 15th of 2020, which was right around the time the entire planet shut down. So that's a really fun time to bring home twins. If we jump in, like I said, I wanted to start off with some current state around high-cost claimants. Looking at some data here on the right-hand side, I have a chart from Sun Life. They're one of the big stop-loss vendors. We can see on their book in 2020, the top claim for them topped out around 6.3 million. That's that purple dot up in the top right-hand corner. It's for a cancer claim. All those other larger, kind of medium-sized dots there, those are claims on their books between 3 and 4 million. All those other dots down at the bottom, those are still claims on their book over $1 million. It's quite a bit of activity. If you flip over on the right-hand side, you can see some data from Symetra, another large stop-loss vendor. And they had a pretty similar experience for 2020, topping out around 7.5 million. So again, not too dissimilar between those two sources. Just out of curiosity, how many people here have worked with a claim over $3 million? All right, what about 5 million? Okay, still see a few hands. What about 8 million? Anybody? Okay, I see one up here. So not only are claims getting larger, they're actually becoming more frequent when we look at the frequency over these specific thresholds. On the left-hand side, some more data from Sun Life, plotting their experience over the last 10 years and looking at the claim frequency over $1 million. We can see over that time frame, the frequency of claims has increased about 300%, or around 17% a year. If you flip over on the right-hand side, again, a pretty similar trend when we look at Symetra's block in terms of that increasing frequency. So again, it's not just the size of those claims, it's also the frequency that we're seeing them over these thresholds. I ran across this really interesting study, at least it was interesting to me, that was done by the Employee Benefit Research Institute. And what they did was they looked at high-cost claimants they looked at them longitudinally. It was over about a 5-year period. So the table here shows the distribution of the population and the corresponding distribution of spend that they would drive. So if we look at the top 20% of claimants, they drove 84% of spend. The top 10% were driving 70% of spend. The top 5, 56%. And the top 1 was driving almost 30% of spend. So again, that top 1%, when ranked by cost, was driving almost 30% of spend. What I think is also interesting here is this kind of reinforces some of those magic distributions that we see elsewhere, like 80-20 and 5-50 splits. So again, I thought that was pretty interesting. The other interesting thing here is these distributions tend to hold true over time, at least as I've seen them over the last number of years. So if we look at data in 2016, 18, 20, 22, even though the nominal figures will change over that time due to claims trend, these distributions will actually, at least so far, have generally held true. I think it'll be cool to see if that continues to happen or if we start to see some shifts. If we map over looking at this top 10% that drive 70% of spend to another study, this one by Milliman, they actually broke out a population that they studied, and they denoted that top 10% as the high-cost group. On average, that high-cost group cost about $42,000 at the time this was studied. The non-high-cost group, or everyone else, the bottom 10%, or excuse me, the bottom 90%, cost right around $2,000. So there's a really significant difference, to say the least, between the characteristics of these populations. There we go. All right. Again, being a huge nerd, I like to find as many sources as I can. I did run across another study, this one by UHC, where they looked at their block. So again, a really large, credible block. They found a really similar result, where they found that the top 1% were driving 30% of spend. Wrapping up with the facts and figures, some of this current state information, I wanted to talk about the profile of high-cost members. There's a visual here, this one put together by Wellmark, and I like how they pulled a lot of this information together. So what they found was 1.2% of members drove a third of spend. So again, that statistic we keep seeing. For this population, they cost on average 29 times the average plan member. That amounts to about $125,000 a year. And then the spend for these members is pretty evenly distributed between what we could attribute to chronic conditions and what could be attributed to acute conditions. If we flip over on the right-hand side, some more statistics from that EBRI study, again here focused on the profile of high-cost members, we can see they're twice as likely to be older, probably not too surprising. They're twice as likely to be a spouse. I thought that was pretty interesting. But they also have much higher rates of chronic and comorbid conditions. These include diabetes, hypertension, respiratory issues, and other comorbid conditions related to obesity. Again, this may not be earth-shattering, but it's definitely a common theme that we'll see throughout the discussion today. So at the top, I mentioned we'd talk about some of what I consider to be the key drivers for high claims activity. I've been researching this area for a number of years. I can generally rationalize about anything that I read or talk to someone about into one of these 4 categories. Starting off with the first one, elimination of annual limits, annual and lifetime limits under the Affordable Care Act. I think this is really the primary driving force behind a lot of what we are seeing. The others would probably still exist, but without this removal of those limits, I don't think they would be as impactful as what we are seeing. The second key driver is advancements in treatments and technology. Here, the focus is on the medical side. We'll talk about pharmacy in a second. The third is chronic condition prevalence. That's where we're going to spend a lot of time today. And then fourth and finally, as I mentioned, pharmacy here specifically focused on specialty pharmacy and some of these new orphan therapies that have come about. Like I mentioned, today we'll spend some time talking about this relationship between chronic conditions and their impact or relationship with high claims. We'll start off setting the stage, again, with just some kind of current state or some facts and figures here specifically around chronic conditions. So starting off with this blue box in the center, based on the CDC statistics, about 60% of adults have at least one chronic condition, 40% have two or more, and 90% of healthcare spending is for people with chronic and mental health conditions. If we flip over on the left-hand side of the screen, there's a really interesting paper that was put out by the Milken Institute, and they studied chronic conditions. What I like about what they did, though, was they studied the direct cost or the treatment cost, what we see in the claims data, and they also looked at the indirect cost, such as lost productivity. Now, we know for a fact that employee health conditions affect their performance and their productivity in the workplace. That includes absenteeism, which is how often members are absent from work because of their health conditions, but it also includes presenteeism, which is when they're on the job, but they're not fully functional as a result of their health conditions. So when you combine the direct and the indirect cost, they found that this amounted to about 20% of US GDP. That is just a staggering figure. Now, admittedly, these figures are from 2016. However, I don't think the picture has improved too significantly since that time, but it's worth noting just given some of that information is getting a little bit dated at this point. If you flip over on the right-hand side of the screen, some information about the prevalence of obesity over the past number of decades. Kevin and Tu talked a little bit about this earlier, but certainly, a trend that we are monitoring. And what they found was diseases caused by obesity and being overweight account for almost half the total cost of chronic diseases. So a very significant relationship when we think about chronic conditions and obesity. Since the chart I grabbed, again, was a little bit dated, I did go back to the source information to get the latest that I could find. Again, based on this source data, last time it was refreshed was 2018. We're now over 40% at 42.4% of the population, adult population, being obese. So again, continuing to trend in that direction. Connecting chronic conditions and high-cost claimants. We find that the average $1 million claimant has between 4 and 5 chronic conditions. Chronic conditions account for over half the spend for high-cost claimants. We saw that earlier. Top chronic conditions for claimants over $1 million include diabetes, hypertension, CHF, cancer, and bleeding disorders. Are any of those sounding familiar at this point? Yeah, any of them related to obesity, you think? Certainly. If we go to the literature, there's actually a really well-established relationship, really well-documented relationship between chronic conditions and large claimants. Schroeder and team found that most high-cost claimants had chronic conditions. Zook and Moore found evidence of riskier lifestyle behaviors like smoking and drinking among high-cost claimants. And Zolman and team, they found that multimorbidity is much higher in high-cost claimants. Here's what I find the most interesting. We've known this for over 40 years. I was really surprised when I started to look at the dates on when these studies were published. I was like, how could we have known this for so long and still be, really not great at managing it? So I think we can do better. If we go back to our definition of chronic conditions, recall that it includes both physical and mental health conditions. We just talked through the impact of a number of physical conditions on high-cost claimants. What about the impact of behavioral health? When I say behavioral health in this context, we're talking about mental health and substance use disorders. So if we go back to that Milliman study, they actually looked at this, and they looked at the prevalence of behavioral health conditions among those populations, being the high-cost population denoted as that top 10% of spenders, compared to everybody else, or that bottom 90%. So the top 10% is shown in the orange bar there on the left. Everybody else are the non-high-cost group in blue. So as you can see, the prevalence for mental health and substance use disorders is more than 2 times higher in that high-cost group in orange than in the non-high-cost group. I think that's pretty significant. So how about we dig in a little bit more? All right, so the chart on the right is effectively a crosswalk between the distribution of the population and the amount of spend that is attributable to them. So that first bar that is stacked is basically this chart on the left, except we flip it and stack it together. So you can see that top 10% there at the very top, the orange and the tan, that is that high cost group. And then we can map over their corresponding spend in terms of the distribution across the total population. So here's what we find. The high cost group that has behavioral health conditions, first of all, they make up, those with behavioral health conditions make up a majority of that high cost group, about 57% versus 43. They also drive a significantly disproportionate amount of spend. Let me say this a different way. So members that are both high cost and have behavioral health conditions make up a very small portion of the population, but they drive a very disproportionate amount of spend. That holds true both in the high cost group as well as the whole population. Another way of looking at this is the non-high cost group. So the non-high cost group that does not have behavioral health conditions makes up almost 70% of the population. That's that light blue at the bottom. But they only account for 17% of spend. So this is a critical relationship that I think we need to understand when we think about how to better manage high-cost claimants. There's one more thing I do think that we should keep in mind when it comes to the relationship between behavioral health and high claims activity, and that's how huge of an impact that COVID-19 had on behavioral health conditions. Going back to some of the Sun Life data, we can see that spend on behavioral health conditions rose over 90% between 2018 and 2021. We can see that claim volume, or the number of claims, increased 70%. And we saw pretty significant increases in spend attributable to depression, sleep disorders, and a moderate increase in spend related to alcohol disorders. So what does this mean? It means that in a post-COVID world, the prevalence and thus impact of behavioral health conditions is going to continue to be a major factor in driving high claims activity. On the last slide, I mentioned there's been a significant increase in spend related to sleep disorders over the past number of years. Kind of begs the question, what about sleep? So is anybody here having conversations around sleep disorders or sleep treatments, or are you working with any vendors? Show of hands, I see a couple of heads knocking. Yeah, okay. So there is a growing body of research that is looking at the impact of sleep on our health, and in particular, the impact of sleep on other chronic and comorbid conditions. These exhibits are pulled from the Frost and Sullivan study, and what they found is about 80% of adults with sleep apnea, or OSA, which is the more common type, are projected to be undiagnosed. That amounts to nearly 25 million people. So how does that happen? How do we have nearly 80% of people with this condition undiagnosed? Well, they found a few reasons. The first, and I think most prevalent, was just patient disregard. People would say, I'm not a good sleeper. It's just, it's me. And then they don't even talk to their provider about it. The second is provider education. When our providers are going through the education system and doing continuing education, so far sleep just hasn't been a big part of that, for, I guess, whatever reason. The third is the cost to diagnose and treat sleep apnea. It can be very expensive. And the fourth was just the duration of the condition. It can last a long time. So of those that were diagnosed, lifestyle modifications were prescribed to 100% of them. So let that sink in. So lifestyle changes were prescribed to everybody who was diagnosed. They also looked at quantifying the impact of having undiagnosed sleep apnea, along with other common comorbidities based on the prevalence in the population. So if you look at this table, do any of these conditions look familiar based on our discussion right now, along with other discussions throughout the day? So as we wrap up this section, I'll first acknowledge, we just covered a lot of ground. I know I touched on a lot of different things. So what does all of this mean? What do you need to do with this information? From my seat, we need to understand fundamentally and completely that all of these areas are highly related and interdependent. Your sleep, your mental health, any substance use issues, your weight, your lifestyle, how active you are, your chronic conditions, and the relationship to or their impact on an acute episode or vice versa, and ultimately how all of these things can drive a catastrophic claim. It's all connected. You cannot address only one of these areas and expect to have a material impact on the prevention of high claims activity. So you might be sitting there thinking, thanks, Wes. Appreciate that pep talk. What are we supposed to do? I'm glad you asked. So now that we've covered in all this gruesome detail the headwinds that we're up against, let's talk about some of the things we can do to help manage high claims activity across all these different challenges. So what I've tried to do is break up my thoughts into what I consider to be foundational techniques, and I hope you're taking advantage of a lot of these things today, either your clients or on your own behalf, and more advanced techniques. Now, when I say more advanced, I want to acknowledge that there are definitely more complex strategies available in the marketplace. What I've tried to do here is keep this very relatable and accessible to the average commercial group. So just keep that in mind as we're going through these. So my suggestions broadly include better analytics and reporting, understanding the importance of predictive modeling, focusing on the management of specialty pharmacy, and then fourth, making sure that payments are accurate. If we take this one step further, we can actually differentiate these two broad categories to retrospective techniques that are more reactive to what's happening and prospective techniques that are more proactive. And that's really what we want to focus on today, is how can we be more proactive? We can then set some objectives around these proactive techniques, and for me, these would be, early identification and intervention, personalized care with a focus on prevention, and substantiated accurate payment. Again, as I mentioned at the top for the session today, we're really just going to be focusing on these first two, being integrating data and predictive modeling. So I wanted to start off this conversation with an illustration. How many of you have ever had an eye exam? Yeah, pretty much everybody, right? So you go in, they sit you in the chair, this thing. They say, do you like one or two? One or two, they go back and forth. I'm pretty convinced at this point it's a trick. They always look the same to me. So humor me. Do you like option one or option two? Option one or option two? Hopefully these at least look different to you. If not, we probably have a bigger problem. But neither one's great, right? Is there another option? Of course there is. There's option three. Is this any better? I don't know, maybe a little bit. Still can't see the whole picture though, right? Can't see all of it. What about option four then? All right, we've got a nice cold bottle of Data Extra, that deserted tropical beach. All right, so I know we're having a bit of fun, but my point here is actually pretty serious. So if your data are not integrated, you can't see the whole picture. That impacts all downstream decision-making and monitoring. So for my sake and for yours, please integrate your data if you're not already today. Let's also not tell the awesome folks at Corona about this example. All right. So between my last two roles working in data warehousing and consulting, I've spent quite a bit of time talking with health plans, with PBMs, with providers and employer groups about their data. I'm continually amazed at how much difficulty there still is with integrating data. It's getting better, but it's still just a massive challenge for many across the industry. When we're talking about managing high-cost claimants, I'm very adamant that it can't be done effectively without integrating medical and pharmacy data at a minimum. For many employer groups, this is still a huge challenge, getting that integrated reporting. I'm talking about medical and pharmacy data that is linked at the member level, so you have that understanding. It's without this integrated data that I think it's nearly impossible to get that accurate and holistic view and where to potentially take action. That includes a proper and fully informed understanding of cost and utilization and practice patterns, being able to pivot that data from a member perspective, from a condition perspective, from a site of care perspective, different types of treatments, demographic views and geographic views. What about benchmarking? Just being able to understand norms and identify anomalies. And then finally, identification of emerging trends shifting from that reactive posture to a more proactive posture. Let's think through a couple of examples. We'll start off with diabetes. We haven't talked about that at all today, right? Yes, definitely have. All right, so let's continue on with that example. So diabetes affects about 37 million people in the US, about 11%. We saw that statistic actually just a minute ago from Kevin and 2. 96 million more are pre-diabetic, and treatment costs span both your medical plan and your pharmacy benefit. So this is a prime example where if your data are siloed, you are fundamentally unable to take fully informed action on controlling that spend and helping your members. A second example is looking at high-cost claimants. Here, going back to some of this data from Sun Life. So starting off on the left-hand side, this is a table of some of their the costliest conditions that they have on their book. What we have is the average cost shown by the horizontal yellow bars. The next column is the highest paid claim for that condition. So what we can see is there are significant variances between the average cost for a condition and the highest cost that could be paid for a condition. If we look on the far right, we can see the distribution between medical and pharmacy. So again, for these really high cost conditions, there's a significant variance in how much is flowing through the medical benefit versus the pharmacy benefit. So the point is, and I won't belabor it too much more, without an integrated holistic view, it's really difficult to properly manage these risks, whether your focus is financial or clinical or both. So just a quick poll, how many of you have ever gotten a report from your health plan for high claims or large claims and a report from your PBM for large claims and you have no idea whether it's the same people or not? Yeah, like it happens all the time. Like we can, again, it's crazy. We can definitely do better. So fortunately, there are some options. I think these will apply to pretty much anybody. If you don't feel like any of these apply to your specific situation, please pull me aside afterwards. I'm happy to talk through and provide my perspective on that. Let me first preface this with the following disclaimer. So every employer group is in a unique and different place when it comes to the business that they operate, the budget that they have to devote to benefits, and the resources that they have available to them, meaning both the number and the sophistication of people that they have to devote to benefits management and the technologies that they have at their disposal. With that said, I think there's still a range of options that are available that everybody should be able to take advantage of one of these at least. So the first option is to lean on your health plan. If your PBM is carved in, they've probably told you you can get integrated reporting. Just please make sure that you are. In my experience, that's still not happening in all cases, so I'm not pointing any fingers. I'm just saying, just make sure you're getting it if they've told you that you should be able to. If your PBM is carved out, make sure that there is an exchange of data, of claims data from that PBM to your health plan, and that the health plan is using that information for more than just tracking accumulators. They should be using it to manage your population, care management, disease management, utilization management, prospectively looking for savings opportunities for you, and of course, yes, reporting. If it's not happening today, I think you're on solid ground to go ahead and demand it from your health plan. Say, look, I need you to do better. Here's where and how specifically. Help me out. The second option is leaning or relying on your broker or consultant. I'm having a lot of conversations with brokers and consultants around data warehouse solutions, and a lot of them are starting to, contract directly for these solutions and then roll them out to all of their clients. This may involve some additional funding or resources, but again, I think it's a really good option if that's something that's available to you. Again, I think this is another area where it's okay to push back on this a little bit. Maybe ask your broker or consultant to pay for this if they're looking to you as an employer. Just say, look, we're both going to benefit from this, so help me out. Why don't you pay for it? The last option is going out on your own and procuring directly a standalone data warehouse. I call this the best solution in theory because it gives you the most control. Now, with that, it can involve more investment. Obviously comes at usually a higher price point, and usually involves more investment in terms of resources, both technology and human capital. But you will have complete control over your data and the relationships. So you can change your broker or consultant, you can change your health plan, you can change your PBM, you can change any of your point solutions. All of your data is still housed in your data warehouse that you control. Again, in theory, I think this is the best option. However, regardless of where you are, there should be at least one of these options for you to start integrating that data and taking action on it. We have spent a lot of time just talking about medical and pharmacy data. I do want to remind everybody here, there's tons of other healthcare data out there that we should be working to integrate. This includes all these different sources that are shown in this visual, but it also includes data on us, on you, on your members. Social determinants of health data. That includes education information about families, incomes, where you live, the different types of lifestyle choices you make, like exercising or drinking alcohol, which are some of my favorites. These all have a major impact on our health, and these are really important data sources, so please don't forget them. The last item before going into the home stretch here is, before going into gene therapies, is talking about predictive modeling. So just a quick show of hands, how many of you are using predictive modeling either with your clients or on your own behalf today? I see a couple. Okay. So there's tremendous interest in leveraging predictive modeling in the management of high claimants. When we talk about predictive models, there's lots of different types that are out there. I generally bucket them into these three big categories, being financial, looking at the prediction of different types of financial risk, such as becoming a high-cost claimant. There's different types of clinical models. So these could be used to look at the risk of a new diagnosis or the progression of a disease, or it could be predicting some type of higher cost utilization outcome, such as an inpatient admission or a surgery. The last being behavioral. So these could look at such things like the likelihood that a member will enroll or engage in a care management program, or remain adherent or discontinue a medication, or close a gap in care. The point here is, if you're using predictive models and risk scores today, that's fantastic. It's a huge way to shift from that reactive to proactive posture. If you're not, I encourage you to start asking your vendors and your partners about these. Ask your health plan, ask your PBM, ask your point solutions. What are you doing with predictive models? How's it affecting my population? So the last topic that we'll go into is talking about gene therapies, hopefully build on a lot of that great material that Rob delivered earlier in the day. Our focus here is to talk about some of the different payment solutions that have been rolled out in the last couple of years. Again, Rob touched on that a little bit. We'll try and expand on it a little bit more. And I'll try and position this with a little bit of my perspective being an actuary. So this first chart is from Tokyo Marine HCC. They're another large stop-loss vendor. And this shows their projections on the cost impact of gene therapies through 2023. I know it's a little hard to see at the bottom, so I've indicated where we are in Q1 of 2023. And this dotted line, the one that goes almost straight up, is their prediction. And so they are estimating that the cost impact on a per employee per month basis, or PEPM, is expected to increase fourfold in 2023 over 2022. So my question for this group is, do we think financially we're prepared for this? Do you think it's been priced in appropriately? That's a bit of a rhetorical question. I don't have a specific answer, but I think it's something to consider for sure. So here's another really fun gene therapy table to look at. So with this one, we're looking at the probability of at least one gene therapy claim in a plan year. So down the left-hand side, we have different group sizes. And then out to the right, we have projections for 2024 through 2029. Now, I picked a group of 2,500 members, just kind of an average mid-market group. And what we find is for 2024, the predicted probability of having at least one gene therapy claim is 1.2%. Do some simple rounding, that's about 1 in 100. If we go out to 2029, that increases to 9.4%, or about 1 in 10. So that is a 10 times increase in just 5 years. Now, I don't want to speak for Rob, but he did hit on this earlier, and this ties in directly with my perspective. I think doing projections, first of all, I understand why this is occurring. It's a very real phenomenon that people need to be paying attention to. I think projecting out a couple of years at this point is really difficult. There are a ton of variables. He talked about Roctavian being delayed yet again. There's a ton of variables. There's a ton of unknowns. I think projecting out 5 years is, I don't want to say nonsensical, but it is a very huge challenge. So I don't want people to get too bent out of shape or focus too much around the specific accuracy of these numbers, but maybe directionally understand that there is a huge pipeline out there. The dollar figures are huge. So again, regardless, this is a very real challenge. It is a very real risk. It's no longer coming. It's already here. And again, there are still a ton of unknowns. So last fall, we saw the most rapid approval and release of multi-million-dollar gene therapy treatments ever. Zynteglo and Skysorna and Hemgenix, you saw those again earlier today. They were all approved such that the highest cost drug in the US changed 3 times in 4 months and now sits at $3.5 million. Historically, again, it's been those health plans or stop-loss reinsurers or some combination of both that have funded these treatments. But over the past couple of years, there's been more dedicated gene therapy payment solutions that have come to market. A few of the common models are a stop-loss type. So this is where the purchaser pays a PMPM or a PEPM for coverage of specific therapies once they satisfy a deductible. A second is a full carve-out arrangement. So this is pretty similar to the stop-loss structure, except there's no deductible to satisfy. So it's a full transfer of the financial risk. Now, for both the stop-loss type and the full carve-out, Again, the coverage is just for those specific treatments, and the administration cost, it would not cover all other member costs that that member might have going on. The third is a payment plan. And this is where the purchaser can pay the full price for the treatment, but they can extend, they're able to amortize that cost over a number of years into the future. So with that payment plan, there's really no transfer of that financial risk. It just reduces some of the upfront cost associated with it. What's interesting about some of these new solutions, and each one's a little bit different, are the additional features that they offer. And I think this is what, in my opinion, really sets them apart from traditional stop loss and reinsurance coverage, which is really just focused purely on that financial risk management component. The other thing to think about here is the following. So if you have an employee and they just received a $3 million treatment, it is very likely that they just became your highest paid employee or one of the highest paid employees. So whether or not you care about this person's well-being, and I hope we do, you just made a significant investment in them. And I think it's these features that help ensure that that investment is successful. And again, this goes back to a lot of Rob's comments earlier today around, just supporting patients in this. We're talking massive spend here. We want the best outcomes. So the first is care management. Again, like I just said, we want the best outcomes for our members. This is one area that I think it's critically important to ensure that members receive the appropriate support and care before, during, and after administration. Some of these new products include access to different types of centers of excellence, different dedicated provider networks. Again, we're talking highly specialized treatments here, very nuanced conditions. So I don't think this should be too surprising, but certainly a feature to be watching for. The second is therapy warranties and performance guarantees. Again, this is another area Rob spent quite a bit of time talking about this morning, so I won't go into too much detail here. But these are just an additional layer of protection such that if clinical outcomes aren't aligned with expectations, or in effect, the drug doesn't work, there is recourse for getting all or a portion of that, your funding or the investment or the cost back. The third big feature I'm finding is data analytics and predictive modeling. I won't go through all the text here on the slide, but here's the gist. So predictive modeling can be used to identify the best candidates that have the highest likelihood of successful outcomes. Data aggregation, analytics, and reporting can all be used to track that performance over time. Again, we also had conversation around that this morning. And that can then have an effect. It can improve future treatment for patients. It can also provide that objective mechanism for determining success or failure. So again, thinking about, hey, if I have a warranty in place or a performance guarantee in place, we need good data to track, how is that patient progressing. So from my very biased perspective, this is an important one. The last thing I wanted to leave you with on gene therapies, specifically as it relates to these new programs, is what kinds of questions I think you should be asking if you decide to start evaluating one of these solutions. So the first is, do I have to be a current customer? So there's a lot of different customers a fair number of customers out there, vendors out there that are putting these solutions together. Some of them you would expect, some of the big names have probably heard of them. Others are, new to market. Because the coverage and the figures are so big, a lot of these a lot of these vendors are requiring you to be a current customer. So before you get too far down the path, like evaluating certain features of a given product, just make sure you understand if there's an eligibility requirement. If, say, you're with company, health plan A today, and you're looking at, health plan C's product, they may not sell it to you. So just understand, what are the eligibility requirements. The second is, what kind of limits are there? So these could be cost thresholds per patient per year. We've seen that. It could be, the number of therapies or the number of therapies per patient per year. There's all different kinds of limits. Just make sure you understand if they are in play, what they are specifically, and how it might impact your population. The third is, will this duplicate any coverage? So if you go out and you purchase a dedicated gene therapy solution and you also carry stop loss, just make sure you're not paying for duplicate coverage. Anything that's covered under that new gene therapy solution should be carved out of your stop loss and should be carved out of the fees similarly, or your fees reduced for that risk that's now covered elsewhere. You do want to make sure that you don't have gaps between those policies. So just like you look at your medical and your pharmacy plan today, and you make sure that that stop loss plan mirrors that coverage, you'll want to make sure you don't have any gaps between anything that you carve out. The last one on this slide. So what is this vendor doing to manage future cost increases? So just making sure that you understand what actions and cost containment measures that they are taking to actively manage current as well as future costs on therapies that are covered. A few more. So how are newly approved therapies evaluated for coverage and incorporated into the future, and how does this affect the fees? So if the FDA approves a new therapy, it comes to market, does that automatically become covered? And do they automatically jack up your premiums for it? I don't know, but just make sure you understand, is that something that's handled at renewal? Is there a long evaluation process? Just understand, again, these therapies are going to continue to be approved and come to market. Just understand up front how it's going to affect both coverage and the premiums. What are care management and member support programs are being offered? And how are clinical outcomes measured and tracked? Again, we talked about this just a minute ago. Just make sure you understand the types of support being offered or not. It's not included in all of them. So again, just more nuance to watch out for, as well as how they're tracking in determining success or failure. The last is what types of recourse are offered if clinical outcomes aren't aligned with expectations. Again, this goes back to that warranty and performance guarantee notion. And just, again, gives the purchaser some recourse if those outcomes aren't as expected. All right, so wrapping all this up, we'll go back to some of the stats that we talked about at the beginning. We know that a very small portion of the population drives a hugely disproportionate amount of the total cost for a group. So what do I recommend? If I put myself in your shoes, the first thing I want to do is just as much as I can with my data. So integrating data sources to build a better understanding and holistic view of members and trends, leveraging new data sources and new predictive modeling techniques to better identify emerging risks and allow for faster intervention. The second is getting really focused on chronic condition management. We know there's a strong tie between chronic conditions and high-cost claimants. This includes both physical and mental health. We know that chronic conditions exacerbate acute episodes, so better management and earlier intervention means a better likelihood of prevention. And finally, managing the financial risks. Gene therapies are here, so watch out for some of those new, again, financial risk management programs that might offer some advantages over the current paradigm. That's a wrap for me. Thank you all very much for your time and attention today. I don't think I put anybody to sleep after lunch. I'm going to consider that a success. Please don't hesitate to pull me aside if you have any questions about anything that I talked about or that fits into your world. Again, thank you for your time and appreciate it.
I'll ask a question. So you talked a lot about the impact of chronic conditions on high-cost claims, and I love the definition you had there, the culmination of all those different factors. So as you know, if you're an employer and you're out evaluating some of the disease management, case management, lifestyle management programs that are becoming more and more popular, how do you go about looking at the value that they create? A lot of them have maybe ROIs associated with them. How do you balance short-term versus long-term? And then what type of data are you looking to get your hands on to make an assessment of how successful they may or may not be?
That's a really good question and a really big question. So I think it comes back to just trying to understand the culture of the organization that you're working in, how paternalistic they are, and understanding what types of resources that you have available to them. Something that I've heard a while back, and I think is so true, is some of the larger organizations out there have 15 or 20 different point solutions, and they like to say that if I added up the ROI or the savings that each one of these point solutions is telling me, I would have negative medical and pharmacy spend, right? So it's like, how do we get all these things working together? And it's a really, really big question. It's a really big challenge. A lot of employer groups are starting to struggle with, I can't detangle exactly what each one of these point solutions is doing for me and the effect that it's having. Point solution A could be looking great, but they're actually just getting a big windfall from, say, another point solution or the health plan or the PBM. So it's a really big and tough question. I think it starts with integrating as much data as you can. I'm a huge fan of data warehouses. So as soon as you can start integrating data, tracking performance, that I think is foundational to then be able to start to measure and track and study, and then work towards disentangling all these different programs and the effects that they're saying that they have. Again, I know that's a little bit of a non-answer, but it's a huge challenge, and I don't think that anybody has, successfully, been able to tackle that one just yet. For me, it's really difficult to take action unless you know exactly where you are today. So it starts with, getting that data integrated and being able to track performance longitudinally over time, and then I think you're in a much better position to start to answer some of those questions. So hopefully that helps.
So I've heard, and I can't count the number of times that I've heard probably over the last year and a half, I'm eating my feelings. And when you talked about behavioral health and sleeping, and the number of employees who have said to our benefits team, I don't sleep at night, or that I'm eating my feelings. They're becoming such two prevalent statements that I'm hearing from family, from friends, from coworkers. How do you start to bring that topic of sleep disorders into what you're measuring for performance, and how to add it to this dynamic right here?
Yeah, that's a great question. And honestly, sleep really wasn't on my radar until about 6 months ago. It just kind of fell into my lap and started doing some more reading on it. Had an awesome conversation with Rochelle and team last night. So sleep is actually a pretty big thing in the transportation world when we think about trucking. But outside of transportation, it's really not talked about that much, at least in my experience. So I've been doing some more reading on it. The short answer is there are a number of point solution vendors out there that are purely focused on sleep treatment. So I think you could start out just having some conversations with some of those vendors. Maybe even start out with your health plan. I know a lot of health plans and PBMs are starting to roll this into some of the solutions that they bring out broadly. I know there's always administrative challenges when you go in to bring a new vendor, so sometimes it's just easier to leverage one that is already existing. Again, kind of going back to that notion that all employer groups are in a different place. So I think there's probably a few different vendors in your network today that you could just ask them, hey, what are you doing about sleep? So I would start there. And then again, going back to this notion of if it's something that you move forward with, then start to track the data and understand, what effect is this having? Again, it can be pretty expensive to treat, And I think there's a growing body of research that's looking, okay, if we treat this sleep, how does it affect other chronic conditions? And how does this affect cost longer term? And that's, again, some really challenging questions because we get so many confounding variables when we structure those studies. It's really hard to tell what is having that precise effect. But that would be my recommendation, is just reach out to your network and start the conversation there. If you have connections in the transportation industry, talk to them, see what they're doing, because I guarantee they're already working on it because it affects them much more directly. All right. Thanks, everybody.